Good morning, everyone. Welcome everyone to MSA Awareness Month and our first webinar. What is MSA and how does it impact me and my family? Let me first share with you our MSA Coalition disclaimer. This educational session is not intended for the purpose of providing medical advice. All information, content, and material is for informational purposes only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. The information provided and supplied through webinars or on our webpage or by any representative or agent of the MSA Coalition, whether by telephone, email, letter, or other form of communication, is for informational purposes only and does not constitute medical, legal, or other professional advice. Now that that's over, I would like to ask our panelists, Dr. Paul Beach and Amy Wynn, to introduce themselves and share their MSA experience with you. Dr. Beach.
All right. Thank you, Lisa. It's really a pleasure and honor to be here with everyone. So as Lisa mentioned, my name is Paul Beach, and I completed all my neurology training at Emory University in Atlanta and did a movement disorders fellowship after that, also at Emory. And currently I'm an autonomic neurology fellow at Beth Israel Deaconess in Boston with Chris Gibbons and Roy Freeman, who are my mentors here. And so my MSA experience has been related to all of my neurology training, particularly in the last few years. So I became very interested in multiple system atrophy as part of my movement disorders training, research that I'm participating in related to that, and also obviously as part of my autonomic training. And it's a real pleasure to be here to speak with folks.
Thank you, Dr. Beach. Amy.
Hi, good morning, everyone. Anything the MSA Coalition has anything to do with is great. So I'm really excited to be here. I'm a nurse practitioner. I've been in the neurology group here at Vanderbilt for a little over 2 years now, and kind of got thrown into movement disorders and happened across MSA in one of our clinical trials and really learned that this population is underserved and underdiagnosed, and it really just speaks to me in my heart. I've learned a lot, but we've all still got a lot to learn. So I'm really happy to meet with you all and have this opportunity today.
Thank you, Amy. Thank you, Dr. Beach. Good morning, everyone. My name is Lisa Hale, and I'm a clinical social worker at Vanderbilt. I first fell in love with MSA Coalition specifically, and more importantly, you, the people of MSA, in 2017, when the convention came to Nashville. I am honored to support you now as a family support services and patient support services representative, and look forward to sharing this webinar with you all today. We are extremely honored that you've all chosen to spend this hour with us. We have received all your questions submitted when you registered, and we'll be sharing them with our panelists over the next hour. However, you have the opportunity throughout this hour to submit questions through the Q&A function on Zoom. If you are having any difficulties, please let us know via the Q&A function, and Casey, who is one of our incredible managers and is our Zoom expert today, will assist you. Now, on to your questions. Guys, I'm going to go ahead and give you the question, and then you guys answer back and forth. Let's have a conversation and make sure we support all our MSA patients, caregivers, and those impacted today. The first question I have is, how do I know this is MSA? What tells me that I have MSA? Dr. Beach, would you like to begin?
So that's probably the most cogent and most important question to ask. So MSA is a challenging condition to diagnose at times because it can look so much like other things that are more common in terms of what neurologists see, and especially movement disorder neurologists. So kind of the hallmark things that we look for when it comes to diagnosing MSA is someone who comes in with a particular set of symptoms and history and potentially responses to medications by the time they perhaps see someone like myself. So MSA, when it is the Parkinsonian type variant, so in other words, symptoms that can mimic and look very similar to Parkinson disease, so things like slowness of movement, stiffness, difficulty with walking, perhaps some tremor. Those are kind of the hallmark things for the Parkinsonian variant. And one of the reasons why it can be so challenging to diagnose, because particularly very early multiple system atrophy can look very much like early Parkinson disease. There are some things, though, that a clinician may look for and ask about that can help them differentiate these things. So one of them is the speed in which symptoms develop. So patients with MSA tend to progress a bit faster in terms of their symptoms. So for example, one patient I was following had moderate symptoms that developed over the course of 6 or so months that were severely impacting his functioning. Other things that a physician may look for is a response to the medications that we try on folks to help with these Parkinsonian symptoms. So the most typical one is carbidopa-levodopa or Sinemet, which is much easier to say. So MSA patients tend to not respond quite as well to the medication or get quite as much out of it. They may also have side effects from the medication that folks with Parkinson disease do not get. For example, abnormal movements of the face. So we call these things dyskinesias. This can be one potential sign when someone takes levodopa that may support MSA rather. And folks may not improve quite as much as we would expect on the medicine. And if they do, that improvement may stop or taper off over a shorter period of time, over a course of months or even a couple of years, faster than we would expect with Parkinson's. One of the other classic things that a physician will look for are autonomic features. So very early orthostatic hypotension, urinary dysfunction, such as having significant urgency to urinate, or inability to ever feel like you can't empty completely. So these are some of the hallmark things that we may look for. But not every MSA patient has these early on, and so that's what can make it pretty challenging.
You've somewhat answered my second question, but I'm going to go ahead and ask, why are so many MSA patients diagnosed with Parkinson's disease first? And obviously, the frustration I'm sure both of you feel in the clinic environment as well as I do when a patient comes in going, is this MSA or is this PD?
So you want me to field that one to start? Yeah, so a lot of it has to do with what I was just discussing. So early Parkinsonian MSA can look very, very similar to PD. And you may not have some of these profound autonomic problems early on in some patients. It's a complicated issue as well because a lot of folks may present first to a general neurologist, someone who doesn't have subspecialty training in movement disorders or autonomic neurology especially. And so they may not be familiar with some of the subtle things to look for in multiple system atrophy.
Amy, Dan asked the question, are you seeing hybrid conditions involving more than one movement disorder? For example, MSA and CBD, cortical basal degeneration?
Not really. Typically, if you have one pathology, I mean, there can always be a little bit of overlap, but you're not really going to see someone that is suffering from two different kind of proteinopathies. It's a little bit different of a presentation, and you deal with different symptoms as far as the patients go. So to a clinician that sees a lot of these patients, they're going to be able to differentiate between the two fairly easily, depending on kind of where you're at in the disease course. But I wouldn't, in my experience, I haven't seen any of that overlap.
Okay. How do I know which symptoms I will get and when they will first appear? Guys, if you both want to take that one, that would be great.
Amy, why don't you start?
Sure. So I have people ask me this all the time, and I tell them I don't have a crystal ball. You'll hear me say that several times today, but it tends to be that presenting symptoms, you kind of stay with those and you don't always develop new symptoms throughout the disease course. Some people have much more cerebellar type symptoms with ataxia or changes in their walking, and some are more Parkinsonian where they have more of that slowed movement, tremor, that sort of thing. So it's hard to know who will develop what, but typically you can kind of stay in that different lane as far as cerebellar versus Parkinsonian.
Okay. Okay. Michael says, help me understand diagnosing MSA type C rather than type P. Kind of when a patient comes in, what's the protocol, Amy and Dr. Beach, that lets you and the patient know which derivative they will have?
So that physical exam is really important, and that's what helps us. More of the cerebellar type is going to have more of this pure kind of gait problem where you're falling or your legs aren't cooperating like you want them to. They're not really going to look like kind of a Parkinson's sort of presentation with more of the tremor and slowed movement. So to us, we're trained to look for kind of differentiate between the two. And so as we kind of follow you along, we should really be able to tell that. And they both kind of present with different symptoms.
Thank you, Amy. Dr.
Yeah,
Beach?
and oftentimes one feature will generally predominate. So you can certainly be classified as having primarily ataxic symptoms, so the incoordination of hand, foot, and eye movements, certain speech patterns. Some of these things will predominate typically as opposed to Parkinsonian symptoms. Oftentimes patients will have elements of both, but one will kind of be the predominant issue as far as a movement problem goes.
Okay. Bob asks, what about falling as a symptom of MSA?
Yes.
So early falls basically should be kind of a trigger or a flag to a specialist that suggests probably not Parkinson disease specifically, but make you think about some of the cousins to Parkinson's, of which MSA is one. So in MSA, you can have falls from a number of different issues. So the ataxia can cause problems with leg and trunk control. The problems with blood pressure control can cause falls and syncope from having a drop in blood pressure when you stand up. And you can have what's called freezing of gait early in MSA as well, which how I like to ask the question when I see a patient is, do your feet ever get stuck to the floor, like they're kind of frozen there? And usually I kind of demonstrate it. It looks like you can't pick the foot up, basically. And usually that's something that will come out earliest when you're turning. So that's often a source of falls in patients as well.
And I love that you said cousins, because I use that term all the time with all of these kind of overlapping diseases. I think that's a question later that we'll get to, but.
Awesome. Is head drop a symptom of MSA?
So it can be. And in general, these postural issues tend to be a bit more pronounced and be occurring earlier on in multiple system atrophy, particularly the Parkinsonian type. The exact reason for the head drop is still a bit of a debate, whether it is purely an abnormal contraction of certain muscles that pull the head down, or that plus a combination of weakness and other muscles that keep the head up. But that can be something that occurs and can be pretty tough to treat. It may or may not respond at all to the medications that we try to provide, especially the levodopa.
Okay. Talk to me, Amy, about MSA speech imbalance. We'll start with Amy and then bring it back to Dr. Beach.
So speech changes.
Speech changes and balance changes.
And balance changes. Okay. So that's another kind of red flag for us as clinicians when we hear this, what we call spastic dysarthria. or a specific kind of change in the voice that I wouldn't necessarily expect with someone who had Parkinson's. Sometimes with Parkinson's, your voice just gets a lot softer, but it doesn't actually change in the quality and the presentation of it. And so that can sometimes help clue us into maybe there's something else going on with this. So that typically is the change with speech that we see. The change with balance can be due to a multitude of factors. It can be from the inability or coordination changes with your brain connecting with, okay, this is how I walk, ataxia, or it can be of getting stuck where I can't get my feet to pick up and turn. A lot of people will notice it, like if they go from tile to carpet or from a doorway or anything that kind of changes the scenery, they get stuck a lot. So that's a question that I'll ask commonly.
Okay. Both of you, can you differentiate between MSA-P and LBD or Lewy body disease? Dr. Beach.
Yeah, so in general, Lewy body disease refers to either Parkinson disease or dementia with Lewy bodies. So these are two conditions along the spectrum of alpha-synucleinopathies, of which MSA is one, in which you have the presence of this accumulation of alpha-synuclein in a particular inclusion inside of a neuron called a Lewy body. And so that is something that you would only see if you were to take, for example, a brain biopsy, biopsy of a nerve that you would have to stain for. MSA does not have these. And so that is one way in which, if you were to perhaps do a postmortem brain biopsy, that's one thing that is looked for in Parkinson's or dementia with Lewy bodies. You would expect the absence of these in multiple system atrophy.
Okay. Amy,
Mhm.
is there any value in going to an MSA clinic as opposed to a movement disorder specialist? And Dr. Beach, you get to answer this first. We're just going to let Amy start.
If you have an MSA clinic that you have access to, then if that's a concern, go to the MSA clinic, because this is, I tell patients all the time, this is common in my world, but it is so uncommon even in a movement disorders clinic. So it's really hard to get plugged in with someone who's seen this, because it is rare, right? And so if you've got access to an MSA clinic, then worst case scenario or best case scenario, they tell you, oh, we don't think that you have that, but you're going to the people that have the most experience with it that are out there.
Okay. Dr. Beach, from your experience, because you have experience at both Beth Israel and Emory.
Yeah, so in general, because here and in Atlanta, we would have folks, and I imagine also in Nashville and Vanderbilt, you have folks coming in sometimes from many, many hours away. Sometimes, you'll even get patients coming in from another country. How I like to approach this is, if you have Parkinson's, if you have MSA, any of these sister conditions, I am a person who thinks that perhaps at least once a year, it would be a good idea to be seen in one of these comprehensive care clinics in that sense. A clinic in which you see either a movement specialist or are at one of these academic institutions that has a lot of experience with these conditions. And then if you have a neurologist who you like, who is closer to your hometown, especially one that could, stay in communication with the subspecialist who's a bit farther away, then you see them kind of a little more regularly. The communication is what's key, though. And, of course, if you really like that neurologist that you've been maybe following with for, the years prior to seeing the subspecialist, and I say, yeah, you should continue to see them. Maybe come see us once a year, and we can see if there's anything we would tweak or maybe suggest to do otherwise.
Fantastic. Thank you, sir. When someone opts to do a brain donation, I understand this individual understands that it gives the family a definitive diagnosis. Is the tissue also used for research?
That depends on how you donate it. And what I've seen. So you can be very specific with the tissue donation as to where you want that to be sent and what it goes to. So you should be able to kind of tell, hey, this is what I want as far as tissue goes and where and what kind of testing, and not just open to research, if I'm think anything different. But
Yeah, I don't have quite as much familiarity with it, but I think it depends on the program to which you may be donating. Obviously, a lot of academic programs in that sense would be interested in utilizing various tissues and things like that for research purposes. But it may also be related to any stipulations you have as the donor.
yep, I think the donor has a lot of choices before that you go in with prior.
And from my experience in working with brain donations, advocate for yourself. If you wish for that tissue to be part of future research, initially ask for it early in the process, and they can make accommodations for you. Or if they cannot, they can give you locations that can give you the type of service that you request. Okay. Jim would like to know, please speak to how you might associate REM sleep disorder with potential MSA in an undiagnosed patient.
Yeah, so this is a question that I ask every patient that I see, either in the movement clinic or in the autonomic clinic. So REM sleep behavior disorder in the last 10 years has kind of exploded in terms of its research and clinical interest because it is at this point more or less considered a prodromal feature of MSA, Parkinson disease, or dementia with Lewy bodies. Now, which one you may progress into if you have just either what's called isolated REM sleep behavior disorder, which just means you have no other condition other than that. It's very difficult to say, and that's actually an intense interest of a study group that's going on across the country, and I think as well as in Canada, called the NAPS Consortium. That's NAPS. To try and get a better sense of what are the features either on brain scans, clinically, historically with symptoms and whatnot that patients may or may not have that would kind of tell us they may be heading in a particular direction. Now, with respect to REM sleep behavior disorder in someone who's already diagnosed with MSA, that certainly can happen at different times during the condition. And the way I approach it is it all has to do with whether it's causing problems. So whether I'm going to treat it or just note it. So for example, if someone is disturbing their bed partner, there are instances in which a bed partner may be hit, for example, or patients can even fall out of bed. And oftentimes patients may be on medications that would make that very unsafe. For example, someone who may be on a significant blood thinner. I would say we should probably try to treat that and try to lessen the movements. But then as far as how that would affect the MSA diagnosis, it wouldn't in particular if I was already pretty confident that they may have MSA.
Okay. This is a really cool question, Agnes. I'm going to jump in a little bit too, but I'm going to let the experts begin. What does an MSA clinic do differently from a movement disorder clinic?
So I think that, it's just more kind of time spent with MSA with this particular population. And we also have had the time to kind of develop that interdisciplinary clinic where we have speech therapy, we have physical therapy, we have everybody there that we need. I take care of Huntington's disease also, and that clinic has just really been a great model to show us how do we bring all of these different people together to make this work. And a lot of, like it was said earlier, a lot of these patients travel from hours away. So if we can get everything is done that day in clinic, then we're going to. And that's where that, maybe once a year tune-up can work in the patient's favor if they have a local neurologist, and then we just kind of see you as needed from there. But it really just opens the opportunity to just see more specialists while you're here, knock out as much as we can.
And I'm going to jump in for a second and say it is one of the most, to me, valued concepts for patients and their families. If we can have neurology, cardiology, urology, PT, OT, speech, palliative care, pharmacy, hospice and palliative care, all within that clinic or on campus for you for that moment in time, a half day, a full day, depending on the clinic, they are all focused on MSA. They are all subject matter experts collaborating at one point in time, not within 10 different silos, but as one silo, working to support you and the family. It is beautiful. I've been honored to be part of the HD clinic for 6 years, and it is a model that we're hoping to replicate with centers of excellence for MSA coming up this year. But I will leave that for Joe and Joe, the CEO conversations later this month. Tom Tate, who is wonderful, he is one of our peer support group leaders. He is asking that we promote all the support groups. My role with MSA is patient and family support, and I can share with you that you are our most important mission, no matter what. And the peer support groups are located all throughout the United States, and they are there to support you either face-to-face or virtually. If you have not located a support group and you need one, please, please, please reach out to us in the chat or send an email to info@multiplesystemaatrophy.org. We will be glad to support you and your family in every way possible with resources, with peer support groups, and many other wonderful things that we will share with you throughout this month. Okay. Moving on, Bob states, we've had movement specialists say that exact diagnosis isn't that important, since the only thing that can be done is treat the symptoms. Does that make sense? Amy, what are your thoughts first?
It doesn't make sense to me because every cousin of these diseases looks a little different and it has a different course. And I always say that with the caveat of this is a really hard diagnosis to make, and it may take us some time to really see how you progress and see how this looks to know what are we dealing with. But I also know what to look out for, what I'm worried about, what I'm thinking about. If it's Parkinson's versus MSA versus Lewy body, they all have different problems. And so me as a clinician, I want to be as prepared as I can for what might come. And so no, we can't fix any of these things, but that doesn't mean that I just lump them all together and kind of treat them all the same, because I don't treat them all the same.
Thank you, Amy. With MSA, do you typically see underactive or overactive bladder issues? Oh, cool question. Dr. Beach.
Yeah, so MSA is a bit tricky in that sense, because you can see actually a bit of bladder overactivity in some patients who will get kind of that overwhelming urge to go. But oftentimes patients will have a sense that they didn't get everything quite out. And so some symptoms of what we call incomplete emptying. And these things, every patient is different, right? So I always ask both of these questions because the treatment for these things is a bit different as well. In general, it's a little easier to treat an overactive bladder than a bladder that won't empty completely. But it's important to make sure to stay on top of these things because bladder issues can cause pretty significant problems in MSA patients, such as urinary tract infections, which can worsen a lot of symptoms. So oftentimes, if I have a patient who suddenly is doing a lot worse, that's one of the first things I think about is a urinary issue, and perhaps something like even an asymptomatic infection in a patient.
Thank you. Amy, is it normal to have difficulties when turning in bed with MSA?
Yes, it can be very common. It can go back to both that coordination problem and also the more Parkinsonian problem of slowed movement. But a lot of times it's difficult to initiate that turn in bed. And so patients can often do it, but it may take a lot longer, a lot more oomph to be able to. So that is a fairly common thing that can happen.
Okay. Michael wants to know, will MSC affect quality of sleep? I'm always tired.
Can.
Okay.
I would want to know about REM behavior disorder would be my very first question. It's under asked, I've learned over time. And a lot of times it's the bed partner that's saying, I'm not getting any rest because they're moving and whapping me all night long. And so that could be playing part into it. Sleep apnea can also happen. And that's really underdiagnosed as well. Can lead to a lot of daytime napping. So I would want to dig a little bit deeper into those sleep issues, but sleep issues in itself are very common.
Yeah, and there are so many different ways in which a sleep issue can manifest as daytime sleepiness or feeling tired all the time. But it's also important to recognize that even if you have a thorough clinician who's asking all these different questions, they may not come up with anything. This kind of general sense of fatigue and tiredness, sometimes profoundly so, it can be a very difficult issue in MSA in particular, and can sometimes be very hard to treat, unfortunately.
Tom Tate gives a wonderful shout out to those that go to the MSA clinic at Penn Med. They have a full day there and he highly recommends. And I will also let you know that there are other MSA clinics hopefully coming up this year. So hang tight, everyone that's looking for that. Our process is coming out soon. Jim asks, how does Parkinson's and MSA affect mental functioning, speaking ability, memory, recalling words when trying to speak? Dr. Beach.
This is a really interesting question. So classically, it's been thought that MSA doesn't really do a whole lot with cognition, so memory, thinking, and things like this. We found out a bit more recently that it's maybe a bit more complicated than that. And there are many potential reasons for this, some of which we've kind of touched on, like sleep issues can have significant impacts on memory and thinking. Orthostatic hypotension, these blood pressure issues, the presence of that, irrespective of whether you have symptoms, we found tends to make a decline in memory and thinking a bit faster or a bit more likely to occur. But generally, MSA patients will not progress to a full-blown, what we call dementia, or an irreversible problem in memory and thinking that's not caused by something other than whatever process is going on. But memory and thinking certainly can be affected a bit more than we used to think it was. And so a clinician should investigate this, ask these questions. And there are medications that can sometimes help, but it also depends on whether there's a precipitating factor that could be addressed to kind of head that issue off at the pass.
Okay, thank you. Gary asks, I understand there are different symptoms that can occur as a person is diagnosed with MSA. Do either of you believe that there are 2 or 3 more symptoms that are required in order for a person to be 100% sure of an MSA diagnosis? If so, what are those symptoms? Oh, Dr. Beach, you're going to start. I'm going to let Amy pick the back end on that one. That's a good question, Gary.
I will do the ultimate hedge and say that we can't be definitively 100% sure unless we have a neuropathologic diagnosis. So even with the most updated diagnostic criteria that came out last year by the Movement Disorder Society, that's really the only way to know for sure 100%. But we do have newer criteria, as I mentioned, that allow us to make a diagnosis of clinically definite, which kind of replaces the old terminology of probable MSA. But I want to hedge again. Every patient is different. And so there are cardinal features that a neurologist will look for. And it's usually a constellation of different things that will lead them towards suspecting and then potentially confirming more or less their suspicion. And that can be things like I mentioned earlier, with like medication responsiveness. Sometimes neuroimaging can be very helpful. So something like a brain MRI can kind of lead you to a more definitive conclusion. But it's usually not the case that someone will say, I'm 100% confident. I would usually say I am very, very confident in certain situations.
I'm going to interject for just a second from a social work perspective and say this journey is incredibly difficult, from the diagnosis to really understanding the symptoms, regardless of whether it's a movement disorder clinic, regardless if it is a MSA clinic or an individual neurologist. Please, please, please reach out to the MSA Coalition. Please reach out to the peer support groups. Please reach out to me personally so that we can connect you with resources to work through these very challenging questions and time frame, because we know this is not an easy process. I do have, Michael has an addendum to his previous question about the sleep study and being tired. He says the sleep study did not show any problems and the CPAP's working well, cool, but he's still really, really tired. What do you guys recommend? Amy?
His blood pressure. I would definitely want to know about his autonomic function. And it's also something that I find a lot that isn't asked, of things like postprandial hypotension, or where you eat and your blood pressure is dropping and people say, no, my blood pressure doesn't drop after I eat. And I say, do you take a nap after you eat? Oh yeah, I'm exhausted. And so we find it a lot more commonly than we think. And there's some medications that can help raise your blood pressure. I'm not saying that that's what's going on with you, but it's a possibility. And if someone starts talking about fatigue, that's one of the things that I look into. And it can also just be this unexplainable fatigue that we don't have a great answer to.
Thank you, Amy. Everyone that is giving me live questions in the Q&A, I'm going to jump over to the questions that were submitted previously so that we do not forget those individuals. I am not forgetting you, I promise. I'm just putting you on a hold for just a second. Both of you, what is the difference in MSA, POTS, P-O-T-S, oh, and I'm going to not pronounce this right, dysautonomia and
Dysautonomia, yeah.
Dysautonomia. Thank you. God bless you. That I appreciate that. And PAF. So again, MSA, POTS, dysautonomia, and PAF.
Yeah, so what I would say is, so dysautonomia is a very broad term that just refers to presumed or confirmed dysfunction of the autonomic nervous system. So this is the parts of the brain and spinal cord, peripheral nerves that handle all these automatic functions of the body, stuff we shouldn't have to think about, blood pressure, heart rate control, GI function, like gut motility, urination, defecation, sweating, even pupillary movements. So all of these things we shouldn't have to think about. If there's either confirmed or suspected dysfunction, that kind of gets put into that very broad term of dysautonomia. Now, MSA and PAF, which is also just kind of abbreviation of pure autonomic failure, are two conditions that cause autonomic dysfunction. PAF inherently so, I mean, based on the name alone, right? And MSA, about 80%, for example, of these patients at some point will have orthostatic hypotension, which is that drop in blood pressure when you stand up. Parkinson's disease can also have this issue, as well as dementia with Lewy bodies. But this is through a process of neurodegeneration, which refers to neurons in various parts of the body becoming sick and dying off and not working as a result of that. This is in contrast to POTS, or postural orthostatic tachycardia syndrome. So depending on who you talk to, this gets a little political and controversial, POTS can be associated with autonomic dysfunction, but it's typically from some other reason. So for example, there are autoimmune conditions that can cause postural tachycardia that is excessive, and that is associated with similar symptoms to what you can get in orthostatic hypotension. So lightheadedness, dizziness, things like this. But a drop in blood pressure should not occur. If it does, then it's not POTS. And so this condition is not caused by a neurodegenerative process like MSA, pure autonomic failure, Parkinson's, dementia with Lewy bodies, but it can be very debilitating for patients. And there are many, many different things that can cause an excessive postural tachycardia. I should note that a postural tachycardia really can't occur in MSA or PAF. In fact, a lack of a heart rate response to standing is something that we look for in the context of a drop in blood pressure when you stand up.
Thank you very much. Okay, I am going to a question from Keith. Keith asked, my mom, who had sporadic OPCA, passed away years ago. I believe this is now grouped with MSA. I'm interested if an additional genetic link has been found to help determine my own risk. And also if there are any tests now available to determine predisposition.
So I'm happy to field that unless you want to, Amy.
No, that's fine.
So OPCA, so that is the abbreviation for olivopontine cerebellar atrophy. That is more classically now associated with the cerebellar form of multiple system atrophy. And that just that is strictly referring to something that you would see on a brain scan, for example. So an atrophy or a shrinkage of particular parts of the brain. So yes, it is associated with MSA now. And with respect to the genetics question, so there will always and forever be an attempt to look for genetic links to these conditions, but by definition, they are sporadic, which means that they are not conditions that you can directly inherit from your mother or father or from the combination of their genes. There are many mimics to multiple system atrophy, some of which are inherited from mom or dad. These are most typically under the category of spinocerebellar ataxias, and those have to be diagnosed with genetic testing. There's no genetic test that you can order outside of an academic research institution to look for associated genes, but there are, with pretty much every medical condition out there, genes that are associated with either a predisposition or perhaps an association with a condition. But that doesn't mean that if you have that genetic variant that you'll get it. That is a different topic. And so to answer the question, there's no test you can order in that sense. One thing that can be helpful are some of the newer methods for detecting the presence of alpha-synuclein, which I think will tie into some of the questions that other folks submitted. So for example, if you have a cutaneous nerve biopsy or skin punch biopsy that's sent off and stained for alpha-synuclein and it's present, you have a synucleinopathy. And it's not going to be one of those inherited conditions that mimics MSA.
And we've
Awesome.
done that
Go
a
ahead,
lot.
Amy.
That question comes up with the SCA versus synucleinopathy. So there are ways to help differentiate it, but it's also presentation, family history, that sort of thing too.
I'm going to lead into the next question, guys, that you have already seen. If you would like to elaborate, Amy and Dr. Beach. I was recently diagnosed with MSA-C. I had cutaneous nerve biopsy in September, which showed 1/3 abnormal areas and confirmed the diagnosis. My first symptoms were a hoarse voice, loss of balance, and multiple falls. Are there any studies? We're going to go into the research realm now. Heads up, guys. Are there any studies which isolate the abnormal protein in my brain?
So yes, well, in a sense. So the skin biopsy is kind of a quote minimally invasive method to detect the presence of this abnormal protein. So what happens is, if anyone is familiar with the punch biopsy that you may get at a dermatologist or primary care clinic, to look at a skin tag or a mole or something like this, it's more or less the exact same process, only there are specific areas that are biopsied, usually 2 or 3, and those get sent off to be stained for proteins that are present in nerves and proteins like alpha-synuclein. And if you find alpha-synuclein in those biopsies, you have a diagnosis of a synucleinopathy, but then it requires the clinician basically input to determine what type. There are potentially some up and coming other techniques that would look at or look for the presence of these proteins or proteins that are suggestive of nerves that are sick and dying, either in the blood or spinal fluid, that would also potentially help confirm the presence of a synucleinopathy, or perhaps parse out which one could be occurring. So for example, my mentors here at Beth Israel, Chris Gibbons and Roy Freeman, just recently put out a paper in the journal Neurology, which suggests that there are patterns for these proteins that can be seen in the skin that can help, particularly in the setting of sometimes relatively minimal clinical history, kind of help determine what type of Parkinsonism you may be looking at, for example. And there are others that are being developed by folks at the Mayo Clinic in Rochester that are looking at different sets of proteins, either in the blood or the spinal fluid. And the thought is down the line, we get enough information and confirmation that constellations of these different proteins and whatnot may help us, along with clinical history. That will probably never go out of style, so to speak. That'll probably always be necessary. But these other tests can be really helpful as well.
Thank you, sir. Amy, ATH-434 drug is currently in the second phase. How are the developments? Can you share the developments for drugs and treatment methods?
Yeah, so ATH-434 has just kind of got going here at Vanderbilt. I can send to the chat that coordinator's name and email address. She gave me permission. If you all want any more information about that, that study is one that I've been intimately involved with for years now, and it's been really cool to see the development over time. There are a lot of inclusion and exclusion criteria, of course, so that would be something that has to be, reviewed on a case-by-case basis. We are the first site in the US to be active. They've got, I think New Zealand was the first. We've got some overseas that have been administering drug, but it's all fairly new. This particular drug is looking at kind of chelating or pulling iron out. So we think that MSA causes either some deposition of iron, or we're not able to kind of lymphatically clear it from the brain. It's not able to rid itself. And so this particular drug has been shown to reduce iron in animal models. Now, this has not been tested in humans yet, so we don't know that. But the hope is that if we can kind of decrease that iron burden, then symptoms will stop and we can halt the progression of the disease. There's some other trials coming down the pipeline from other countries that are looking at kind of targeting some different things. So one of those is looking more at targeting alpha-synuclein and kind of changing that protein where it accumulates. Those are the kind of different areas of research. It's all really new. Medication-wise, there's not anything yet. That's what we hope to find with these trials, and be able to offer more disease-modifying treatment and not just symptomatic treatment. So that's the important part of research, but we don't have anything today that I can say, yeah, go out and get that. I would say there's a lot of misinformation out there, and people get, sucked into these really expensive vitamins and minerals and all this stuff that just doesn't have much backing. And so just be cautious and talk to your provider about it. because we need to know what you're taking too, especially in light of these clinical trials. So that's kind of where we're at research wise.
Thank you, Amy. Yolette and Heather, you have two questions that are similar, and I'm really conscious of time because I see 13 questions and I'm going to try to get through 13 in 8 minutes. So here we go. Speed round. Yolette, you want to know clinics on the West Coast. Heather, you want to know if you live in a remote area. Ladies, please do me a favor. I have your email. Give me your email. I will send you referrals for areas for doctors that we know are experts in that area of MSA so that you can access them, and I will work with you individually offline rather. And again, our email is info@multiplesystematrophy.org, and that's all one word. Everyone, this is huge. This is a good one. Could you discuss palliative care? At what point in the MSA journey would you suggest that a patient engage in palliative care? Amy.
It's a big question, and it's one that you have to come to with your provider. I like to err on the early side because it's a lot harder to get these things in place once there is more progression. So we're really lucky to work with a palliative care nurse practitioner here that has a lot of experience with our patient population, and he's a great advocate as far as, you know, getting even legal documentation in place. What's the plan? What are the long-term goals? And I just really strive to push patients to think about that as early as they can. That doesn't mean, yes, I'm going into palliative care and I'm giving up or going into hospice. It just means I have these things in place so that as this progression happens, we all are on the same page and we can make this happen. I've learned the hard way that things like custom wheelchairs and medical equipment take a long time. And so just getting ahead of it as much as we can, I'm always for that.
And I'll interject for just a second and say, if we can understand your wishes and we can have those documented, then as an interdisciplinary team, we can work with you to do the things that you want to do. Because we know what your wishes are, we know what you would like and what your needs are, so that we can focus on helping you live the best quality life that you can now. Great question, thank you. Okay, Dan wants to know, I have a trach caused by a vocal cord issues and stridor, not to mention aspiration pneumonia. This is accompanied by a feeding tube. How common are tracheostomies and feeding tubes in your patient populations? Amy.
I don't have a ton personally. Everyone is very different again with this, but just in my personal experience, I don't think I have any patients that require trach. More commonly, it's support at night with like a BiPAP or a CPAP machine, because it can be more of this stridor or difficulty with breathing at night. And as far as a feeding tube goes, I kind of keep a close eye on people swallowing, but I haven't had a particular patient require one at this point with dietary modifications. Again, everyone is really different, but I wouldn't say that it's a very common thing in my practice. I don't know if Dr. Beach has any different experience with it.
No, I more or less the same as you, Amy. But I think this ties very closely to the prior question about palliative care. This is something that palliative care discussions are inherently designed to address early on. If something like stridor comes up and it's bad enough that we're worried about your respiratory function, what do you want to do about this? So that we know ahead of time, this is what we're going to do. This is how we can support you. Do we want advanced treatments or not? So it all has to do with what your values are and goals of care. And for that discussion to take place, ideally from an early time, well before something like this would happen, if it's going to happen.
Awesome. Thank you, sir. Thank you, Amy. Agnes, I see that you live in New York and you want to find the nearest MSA clinic. Send me your email if I don't already have it. And I will get you to what we know to be an MSA expert in your area. Yolette, I already have your email. And Jim, you are asking, or you are giving them an incredible compliment. You are experts in dealing with this terrible disease. What suggestions can you offer when patients and caregivers are interacting with uninformed healthcare providers, such as the ER, first responders, and PCPs? Amy.
I tell my patients all the time, give me your local neurologist or your local doctor's phone number and we can talk through this. We're kind of used to no one knowing about these diseases, so we're kind of used to these conversations. I have a lot of social work support, which is huge in making those phone calls and saying, getting ahead of it and saying, hey, this is what this disease is, and this is what we are worried about, what we're thinking about. And so it's really just having that active relationship with a social worker that can really make a difference. I've also had patients they might not all love this answer, but having like a Parkinson's disease bracelet or just something that kind of clues people into a more common disease. And so they still can kind of get an idea of what's going on, even if it's not specific.
And your social worker or your nurse practitioner or your physician can write a letter, and you can laminate that letter. You can have it in a binder. So if you are going to the ER, it can be in your notebook, it can be in your car, it can be in your purse, it can be in your wallet, anywhere where somebody can say, see, I have MSA, these are the challenges that I'm having. And that clearly allows individuals that are naive to MSA help understand what your symptoms are. Jim, you hit the biggest thing in the world, and that's your social worker, if you have access to one, physician, primary care, whatever. But we will help you. If you have further questions and you have specific ERs or PCPs, we can send out an MSA packet from the MSA Coalition to educate that group of individuals as well. So just let us know and we'll be glad to support you however you wish. Okay, guys, I am so sorry, but we are nearing the end of our hour. Casey, if you can show me one more question, we'll take that question. Let's see. Perfect. If someone with MSA-C has an MRI which shows a hot cross bun sign, can a doctor and or nurse practitioner make a definitive diagnosis? Starting with Dr. Beach.
The answer is no. It does point you in the right direction, though. And this ties back to one of the conversations we were having earlier about mimics. There are conditions that can have the quote hot cross bun sign that are not MSA, though it is classically associated with MSA, particularly MSA-C. But it's something where the imaging cannot make the diagnosis. It's a combination of that, your history, and the examination.
Awesome. I lied. One more question. Is back pain a chronic complaint with MSA? That's a great question. I don't know the answer. Amy.
Coat hanger pain. So pain, one is a big question, is really misunderstood in MSA. Oftentimes people have what's described as coat hanger pain or pain kind of across the shoulders when their blood pressure is getting lower. And so that can sometimes be teased out and even treated with blood pressure medications to help raise it. But I would also put that with the caveat of pain can just be really misunderstood in MSA. And so we might not have a specific answer for it. It could also be related to something like dystonia or muscle stiffness that can sometimes respond to Cinemet. So yes, the simple answer is pain is fairly common.
And you're also allowed to have more than one thing.
Yep.
So you can have back pain for other reasons. Sometimes the MSA can make it worse. So patients who get a little bit of response to levodopa, sometimes if they're stiffer and you give that medicine, some of that pain will get a little bit better. But the dopamine system that's involved in MSA is definitely involved in pain and pain processing in the brain. So there are complex relationships there, but you can't assume that it's not related. You can't assume that it is. So it's, again, a good clinician is going to ask questions to kind of clue them in onto what could be going on. And then you work together to figure out what helps you the most.
Everyone, I am so sorry to say we're nearing the end of our hour. Actually, we're a minute over. I'm sorry, Casey. Everyone, thank you for your trust, your vulnerability, and ability to share your questions with us today. We are honored to support so many of you on this call from the United States, Turkey, Canada, the UK, New Zealand, Nigeria, and Australia. Please know that if we did not get to your question, and I have 7 open questions, and for that I sincerely apologize, we will follow up individually with an email. We will also follow up with a Zoom email to each of you who have registered, asking you to complete our survey. Please let us know how we did and how we may improve to continue to work and support you as the MSA Coalition. Finally, this webinar will be recorded and available should you wish to watch at a later time. We look forward to seeing you throughout the month at our other MSA awareness events. If you have any questions, again, please reach out to us at info@multiplesystemaatrophy.org. Thank you so very much and enjoy the rest of your day. Dr. Beach, Amy, thank you so very much. Have a great rest of the day. Bye-bye.
Bye-bye.